Professor of Cardiology and Director of the Kirchhoff Heart Center in Bad Nauheim. It's my pleasure to talk to you on the pharmacological therapy of patients with non-ST elevation acute coronary syndrome. Here are my disclosures. The thrombus formation is the key pathophysiological process in patients presenting with acute coronary syndrome. And accordingly, the anticoagulation and antiplatelet management are key to improve the prognosis of this high-risk condition. And that's why I will address during my talk aspects of anticoagulation to improve the prognosis as well as the best antiplatelet management of these patients. Let's start with the antiplatelet management. Of course, aspirin has more than for 30 years now the standard management of patients presenting with acute coronary syndrome and has to be included in the management. However, aspirin is only a very weak antiplatelet drug, and we have more potent antiplatelet drugs that are the ADP receptor antagonists or P2Y receptor antagonists. And that's the clopidogrel, around for more than 10 years, and the novel drugs prasugrel and ticagrelor. Clopidogrel has been the standard drug for many years, although its action is a little bit unpredictable and the onset of action is only after a few hours. As opposed to prasugrel, which is an irreversible binding drug that has a much faster onset of action and also is much more potent. The same is for ticagrelor, which is reversibly binding to the P2Y12 inhibitor, has a fast onset of action and a somewhat faster offset of action. And it's also a very potent antiplatelet drug. There have been studies that performed comparing clopidogrel with prasugrel and ticagrelor, and these studies entered the guidelines. You see here in the guidelines that based on the Plato study that there's a recommendation formulated that says that patients should be loaded with ticagrelor if they are moderate to high risk for ischemic events, particularly patients with elevated troponins, regardless of the initial treatment strategy, including patients pre-treated with clopidogrel. Then of course clopidogrel should be discontinued. This statement is based on the Plato study. The Plato study showed in its primary endpoint, a combined endpoint of cardiovascular death, myocardial infarction, and stroke, a significant reduction of events. Most importantly, this study also showed that the heart endpoint, myocardial infarction and cardiovascular death, are significantly reduced. And this was seen in patients treated conservatively, these are the blue lines, as well as patients treated invasively, these are the red lines. So this was consistent finding across all treatment management groups. That's the reason why it's so highly ranked in the guidelines. Now, the other drug is prasugrel. Prasugrel was tested in the Triton TIMI-38 study, which is slightly different from the study design as compared to the Plato study. That's why the recommendation is somewhat different. The treatment prasugrel is limited to patients that have already had coronary angiograms and the coronary anatomy is known and that are planned to go on to PCI. So it should not be given to conservatively treated patients. Now see here the key finding of the TIMI-38 Triton trial, which showed a significant reduction of the heart endpoint, again death, myocardial infarction and stroke, with a number needed to treat of 46. This was associated with a small increase in bleeding, but the benefit overall was much greater. However, there are some exceptions. Some patients did not benefit. Patients that were elderly had no benefit from prasugrel, and patients that were under 60 kilograms also had no benefit from prasugrel. And patients that had a previous stroke or TIA even had some harmful events when treated with prasugrel. Therefore, these patients are excluded from prasugrel. Now, what is left over for clopidogrel? There's not much left over for clopidogrel, and the recommendation in the guidelines are very clear that clopidogrel is only recommended when ticagrelor or prasugrel are not available. There are another group of antiplatelet drugs which have been around for several years and which are given intravenously. These are the GP2B3 antagonists. They block platelet aggregation, not platelet, they do not inhibit platelet activation, they block the platelet aggregation. That's why they play an important role. Let me start when they should not be given. They should not be given upstream as recommended by the guideline. They should not be given routinely to all patients, but they do have a clear benefit in selective patients, particularly in the high-risk patients undergoing PCI. In these patients, particularly troponin-positive patients, will have a benefit. Now let's switch to anticoagulants. The guidelines state very clearly that all patients should receive, next to the antiplatelet management, also an anticoagulation. And here it depends a little bit what strategy it's followed. If it's more conservative management, then fondaparinux is the preferred choice. You see here, this is based on the OASIS-5 study, which demonstrated a significant reduction of bleeding in patients treated with fondaparinux as opposed to enoxaparin. And this translated into a mortality reduction over 30 days in fondaparinux being better than enoxaparin. That's why, according to guidelines, this is the first choice. This is a little bit different in patients that undergo PCI. In these patients, bivalirudin is the preferred choice and should be given over unfractionated heparin in combination with your GP2B3 antagonist. Although this is not widely used in Europe, still has the highest rate of recommendation based on several studies. Now, let me come to the discharge of the patient. You see here the list that's recommended in the guidelines, and you see that antiplatelet drugs play a major role. Aspirin and the P2x12 inhibitors, they should be continued for 12 months. And there's some other drugs which I could not address in detail, which are very well known to us, that beta blockers should be given to patients that have a depressed left ventricular function. That's also the same case for ACE inhibitors or the angiotensin renin blockers. Also, the aldosterone antagonists, namely eplerenone, should be given to patients that have left ventricular function. Statins play a major role on the discharge management, and of course it's also recommended by the guidelines to change your lifestyle. For more detailed information, I'd like to refer you to the homepage of the European Society of Cardiology, and you can there pick up all the essential messages and the essential recommendations and download this for free from the internet site. Thank you very much for your attention. The ACOAST trial is an important trial that confirms the messages of the ESC guidelines. The ACOAST trial tested whether prasugrel upstream 4 hours before PCI is of advantage as opposed to a prasugrel given on the table when it's decided to go on with PCI, which was more or less the Triton protocol. And this trial confirmed that the upstream treatment is of no benefit for the patient. There's no reduction in events, and you only increase risk of bleedings. Therefore, the concept of how to manage patients with non-ST elevation acute coronary syndrome remains as it is in the guidelines. You may go on to coronary angiography, and if you find lesions and want to go on to PCI, then you may load the patient with prasugrel. This patient will have no benefit if you do an upstream treatment with prasugrel.